peritoneal approach of laparoscopic kidney surgery, and to say that we have some technical options which can be different, but you will observe that in my videos you will find many similitudes with what was described by Christian. And at the end of this talk, before the break, I would like to talk about the possible indication of laparoscopy for treatment of specific kidney stones, and I'm going to show you a small movie. About pyeloplasty, as you know, the only reference treatment of structural junction will be the pyeloplasty, and as you know, before the age of laparoscopy, this surgery was performed with open surgery, so it imposed a small skin incision, and at this time it has been developed some alternatives with endoscopic approach to avoid this problem of open surgery, and it was a time of percutaneous success of the kidney to try to perform endopielotomy, and it was a time of retrograde endoscopic access with the ureteroscopy to try to perform with endoscopic blade or laser endoscopic incision of pelvic obstruction. And at this time was developed the possible laparoscopic approach of the kidney, and because of quality of the surgical technique of laparoscopy, incidence of endopielotomy and retrograde ureteroscopy has been progressively decreasing because the quality of the treatment was not so good that was wished with pyeloplasty. So this mini-invasive surgery was very nice indication for pyeloplasty. And Christian said it was possible, and it has been developed at this time in both ways, extraperitoneal and transperitoneal one. So we are going to talk about the difference of the both way tomorrow during the topic of radical and partial nephrectomy. But about the pyeloplasty, I think that every team agrees to say that the best way is the transperitoneal one, just because your space is very large and very easy for the job of suture, because it's the main part of this surgery to perform laparoscopic suture, and because of the problem of crossing vessels. And if you find crossing vessel in the transperitoneal way, you will find the first vessels and then ureter, and you will build the pyeloplasty with in front plane pyeloplasty, in the back plane vessels, and of course it will be inverse in extraperitoneal access. That means that sometimes in the posterior access with extraperitoneal, you will be in front of you with large crossing vessels, and you have to deal with a difficult exposure for the job of the suture. So it is considered like the best recommendation about your way of access. It's a transperitoneal way, just for the pyeloplasty. If you have the objective to perform the transperitoneal kidney surgery, you have just one good position. It's a complete lumbar position. That means that you are laying the body of your patient on the opposite side of the side that you have to treat. And it's very simple because of the transperitoneal characteristic. You don't need to angulation of the table, and you have just a very simple procedure, Foley catheter before moving the patient in the good position, and you can perform this surgery with just one surgeon and one assistant. I don't go back on the patient position because Christian described already. Just to remind you that the complete lateral decubitus is like this. You are on the side. Your limit of abdominal wall, which is on the limit of the table, just to avoid some limits in your laparoscopic tool mobilization, and you have just to organize the posterior support to be sure of the safe position without risk of anterior mobilization. And the body is just sticked with this kind of adhesive tissue to give a pressure between body and the posterior support. And you have observed that thanks to immediate complications that we met in laparoscopic surgery, we have understood that it was mandatory to give a protection of skin and muscle with this kind of small structures with a gel, which avoid any suffering contact between skin and muscle. What you need is just entire part of abdominal wall for placement of the port. Your field will be limited between the iliac area, between the limit of the ribs, and between the median line with umbilical landmark for the side of the kidney that you have to treat. Christian described laparoscopic instruments. You are going to observe that during this course, every surgery will be presented with the same kind of instrument. That means that the laparoscopic surgery is very cheap because you just need a box of laparoscopic tools which can be reused. And depending on surgery, perhaps you have to add some specific tools, but your basic instrumentation is summarized on this picture. Needle driver, of course, bipolar grasper, necessary. Laparoscopic scissors, which are here. Laparoscopic grasper, a large one, a thin one. Laparoscopic lens, 0 degree, except some specific situation on partial nephrectomy and prostatectomy, but your usual lens is 0 degree. And then you have the ports equipment, and I'm going to show you, and Christian already showed that you can use very nice quality of single-use ports, which are very easy to use. And if you have to deal with economical limits, you can find some reusable ports which decrease the price of your surgery. About surgical instruments, we said when we started the surgery with laparoscopic approach, it was mandatory to prepare before starting your first port placement a surgical table to be able to converse in emergency if necessary. I think that it will be mandatory for nephrectomy, but not systematically for laparoscopy because for pyeloplasty, excuse me, because risk of accident is very low in laparoscopy pyeloplasty. About material, Christian said, and I agree, monochride, it's a reference stitch, and I completely agree about the question of VLOC for the pyeloplasty, because VLOC is an armored stitch, and so it induces very strong inflammatory reaction for the thread resorption, and I think it will be an argument to increase the risk of stenosis in your pyeloplasty. Out of this limit, VLOC is a very, very nice suture for many indications, but I think that it's not a good one for the pyeloplasty. We need a guide and we need the stats we are going to describe during the stitch. Port placement is exactly the same that Christian described. As you know, laparoscopic surgery will be summarized with a theory of triangle. That means that your field of laparoscopic vision will be organized with the external placement of the port respecting the form of triangle. The tip of triangle will be a lower part of your surface and will be used by the port placement to drive the lens. So for the pyeloplasty, this port is a 10 millimeter one to introduce a large size of port which is able to drive the lens, and the laparoscopic instruments port will be of 5 millimeter, and we use two external as the limit, excuse me, two external as the limit of the triangle. The first one just 1 centimeter above the limit of the rib, second one in the medial part of iliac area, and the third one will be at the middle distance between the two external previous described port. About organization of the team, I said that it's very simple. You just need an assistant for driving your lens and your laparoscopic tools to give you exposure. That means that you can observe in this slide, and the question side, very resting position, no crossing movement between the arms of the surgeon and the assistant, just to save the gest. And so in this left kidney surgery. Assistant will be at the lower part of the body, driving the lens with the left hand and driving laparoscopic tools with the right one. And surgeon will be at the higher part of the field, driving a medial part with the right hand for scissors and needle driver, and the left hand to drive monopolar big valvular grasper and thin grasper for the time of the suture. Just before starting a movie, I would like to go back on a very important aspect. One has been described technique of laparoscopic pyeloplasty. Because of difficulty of long time of laparoscopic sutures, it has been tried to perform mini laparoscopic pyeloplasty. For example, it was described like YV, that means that you divide the pelvis with horizontal limit and you suture with the vertical one just to enlarge the passage. And this kind of simplified pyeloplasty are not a good option because usually the result is not the best one. And so you can give a bad credit to the laparoscopy just because the job of laparoscopic pyeloplasty is not the good one. So if you decide to move to laparoscopic pyeloplasty, it's to perform the referent and the only good technique, which is Anderson eye, described by Christian already. That means you have to divide the pathologic aspect of the junction, you have to perform a small resection of the pelvis, and you have to spatulate to enlarge the size of the anastomosis, and you have to deal with the suture between your ureter and the pelvis. So we are going to show a small movie. Just before moving to the movie, just to summarize, as you know, we are in the transperitoneal way. That means that, of course, we are going to find the colon and the bowel in front of the kidney. On the right side, it's not a specific problem because usually the right colon is just covering the lower part of the kidney, and usually it's possible to access directly pelvis and ureter without any colonic mobilization. What we have to deal on the right side, and it was said by the oral message this morning, it's a duodenum, because as you know, duodenum is covering the anterior part of vena cava, and sometimes to find the ureter, perhaps you have to deal with the duodenum, which has been mobilized very safely to get free access on the ureter. On the left side, it's completely different because it's impossible to access anteriorly to the kidney without previous colonic mobilization, and so we have to deal with the tall fascia division, mobilization of the colon, and finding a psoas muscle that we are going to see this approach on the movie. So, David, on est sur right pyeloplastie, je pense. Okay, so it's exactly the same situation that described Christian in his movie. So you will